Welcome everyone to the AMA WA COVID Preparedness Seminar tonight. Are you COVID ready? So before I introduce the webinar, I'd like to acknowledge the Whadjuk people of the Noongar Nation, the traditional owners of the country that we're meeting on, the elders past, present and emerging, and all of our responsibilities to help close the gap. My name is Ben Ing. I am the CEO of AMA WA, and it's my pleasure tonight to host this webinar, especially for us living in Western Australia, where we are still trying to actually get ourselves ready. The webinar tonight will be recorded. All the participants will be on mute, and we welcome all of you to put your questions in the Q&A panel that you can actually access. So the panelists will see the questions and please keep them going. So joining me tonight, we have three experts. We've got Dr. Jonathan Chambers, Dr. Karina Powers, and Dr. Jane Deacon. Dr. Jonathan Chambers is a consultant clinical microbiologist and infectious disease physician in Western Diagnostic Pathology and across Path West and King Edward Memorial Hospital. He's also a consultant ID physician at Joondalup Health Campus and was the COVID-19 clinical lead there since 2 years ago. Jonathan's also on the AMA WA Council. Dr. Karina Powers is a consultant occupational environmental medicine specialist with a Master in Public Health. She's practiced in private occupational health clinics in Perth, servicing a mixture of private companies and government agencies. She's also worked in public health, communicable disease and research in the Department of Health before, and her main interests are prevention of injury and diseases, early intervention, and rehab. But over the last 2 years, she's joined the AMA WA Council and has been extremely proactive on COVID-19, and she's also a member of Osage. Dr. Jane Deacon joined the MDA National in 2006 and is the manager of medical legal advisory services. She was a GP and ran her own practice for many years and continues GP in part-time. I'm not sure whether it's still this year. And in 2016, she completed a postgraduate diploma in health law from University of Sydney. So, and we're very grateful for the support of MDA National for this webinar as well. So tonight we'll first hear from Dr. Chambers and Dr. Powers, about 15 minutes each, and then we'll be followed by a Q&A session with the whole panel. So if you've got any questions, please pop it into the Q&A button that's on your screen. So Jonathan, if you can start us off, please.
Hello, Jonathan Chambers. Thanks, Benny, for the introduction. Now, I'm going to talk for about as long as it takes to run a rapid antigen test, and I promise that I will only stick to that long. But Benny will interrupt me mid-talk if I go over, because I do have a reputation for talking a bit much. I worked up at Joondalup and was the COVID clinical lead when we had the Artania cohort back in the beginning, where we looked after about 43 patients. Since then, Western Australia hasn't had an awful lot of cases, and recently we did have a Omicron case come through our hospital, but really we have been free of any experience, which is probably a good thing. So most of what I'm talking about tonight is stuff that I've gained from previously, and things that we're learning from our colleagues in other parts of the world and over in the eastern states. So this slide here is one of the original from the original paper describing COVID-19, the original strain. And apart from maybe a couple of days difference, so things with Delta and Omicron are happening maybe 2 days before the original cases. Nothing's really changed that much with the clinical trajectory of patients that are going to end up coming into hospital who get sick, who then go to ICU, who then go and unfortunately pass away and do badly. So this is kind of the same thing has been happening all the way along. So it's worth keeping in mind what lessons we learned and what we knew in the beginning. And this sort of slide I haven't seen yet for Omicron, but it will come through. And on the topic of Omicron, you know, in Australia, this all sort of kicked off with some political decisions, perhaps in line with our overarching plan and desire in other parts of the country to push on and open up. And we've had more COVID cases in the last 3 months than we've really had since the very beginning. And it's definitely a different world on the other side of the country. So Omicron, the Omicron variant is the one that's responsible for now really taken over. The last I looked, and in my laboratory, we've done a lot of testing for New South Wales, as well as the Northern Territory. And the last time I looked at our sequencing results, over 98% of everything that we've had sequenced so far has come back as Omicron variant. So the Omicron variant is essentially completely taken over from previous variants of concern, largely the Delta variant. So the differences between this and other ones, and I really, you know, don't get much chance to get nerdy about viruses, but really the big difference in this is there's a few mutations, and the one that makes the biggest difference to us are the 32 mutations that affect the spike protein. And also about, there's a number of them that affect the receptor binding domain as well. So those are really critical components of the virus for which all of our vaccines that are effective target different regions. Now, this virus, lots of people in the media will say it's much more transmissible, it's much more contagious. And the reality is that, yeah, there's probably a little bit of that, but it's probably not much worse than Delta was. But the big difference is that this is essentially the vaccine escape mutant that we all kind of worried about. And so there's a little bit of increased transmissibility, but the reality is that this is affecting lots of people who are vaccinated as a result of it being essentially a vaccine escape virus. So some of the drugs that they developed are no longer effective. So all of those antibodies with funny names, like Regeneron and all of the names that go with that, a lot of them have been found to be wholly ineffective against this variant. Sotrovimab still has a little bit of activity, they think, but I'm not aware of like what that activity is compared to the original trials. It appears as though, or we assume that the non-antibody based therapies like the new Paxlovid, which is basically a protease inhibitor, and molnupiravir, which doesn't really or isn't affected by these mutations, should be as effective, or we believe they're as effective against this as other variants. Now, it's very clear the other difference with Omicron is that there is a decoupling between the case number and load and the admissions to hospital and death. And that's become very clear over time. However, as a result of the high case numbers, there's still a high impact of this illness on our hospital system, particularly with this vaccine escape capacity. So, you know, we don't really know what this is actually going to be in an unvaccinated population, or a population without any exposure to any previous variants. So say our Pacific Island nations, which have also been essentially COVID-free, but who don't have very high rates of vaccination. The fortunate thing about this, despite being a vaccine escape mutant, really, there is still a pretty preserved vaccine effectiveness, even taking into account its less severe sort of illness. but it still gives us significant protection against severe disease, but not against infection to the same extent. And the Omicron, like the Delta, has a higher affinity to the ACE receptor, which is previous variants really didn't infect children to the same extent as these new variants. And one of the reasons is probably because of this higher affinity to the ACE receptor, which makes them slightly more infective, and also means that children who have less ACE receptors in their upper respiratory tract are probably more susceptible to infection. But this was similar with the other variants of concern as well. Vaccine efficacy. So there are lots of papers now, really test tube papers, that show that there's reduced neutralizing titers against Omicron in individuals who've received primary vaccination or prior SARS infection. So really what that means is that you need many, many more antibodies or be early in your sort of from receiving your booster or whatever, to have a very high level of antibodies to have any neutralizing capacity. We know that there's waning vaccine efficacy months after booster doses, which is in keeping with this. And, you know, we still think that there's significant reduction in hospitalization from receiving vaccine, particularly boosted. But it's very clear that, and I've seen down as low as 15 or 20% sort of efficacy against preventing symptomatic disease. But the WHO seems to think that it's closer to 40. So it's not stopping the virus like we hoped. It's not stopping the virus like the modelling suggested. Most of the modelling that was used in Australia had vaccine efficacy at preventing symptomatic infection of around 75, or West Australia's modelling really was 85, I believe. So you can see that the Omicron variant just blew all of that out of the water. So, you know, this seems to be the strategy in lots of places, including WA, is to just keep giving vaccines. And, you know, Israel's up to the 4th booster. However, I mean, it's kind of clear to me that vaccine alone is never going to be the number one thing that's going to stop this pandemic. It's going to be a collection of things, including public health interventions, vaccines, but probably treatment as well. Otherwise, we're just going to keep giving vaccines, and we may end up keep giving vaccines forever and ever, like we do with the flu. So I'm going to move on a bit to rapid antigen testing, which is kind of the other popular thing at the moment. So rapid antigen testing, you know, everyone knows this. It's not as sensitive as PCR. And I'm going to go into the pathology statistics stuff as well. But while the prevalence is low, and to be honest, the prevalence is still low, we may be in the beginning of like the highest numbers of cases that Western Australia ever had. But the prevalence is still very low. It's still less likely that a patient that presents to your clinic actually has COVID, but they could. But it's got a very good negative predictive value. Like when we do a test, really the sensitivity and specificity is all good, but what you really want to know as a doctor is when it's negative, is that a true negative? And when it's positive, is that a true positive? And really the most important factor is actually the prevalence when looking at that, as well as the sensitivity and specificity. So, you know, at the moment, the negative predictive value of a rapid antigen test is pretty good. It's almost as specific as a PCR, 99.5% versus about 99.95 or higher. So whilst the prevalence is low, though, the positive predictive value isn't that good. But the positive predictive value of the PCR at the moment is also not the best, although it's going up with rising case numbers. So, you know, we talk about tests being better or worse and accurate or not as accurate, but really you've got to think about how much disease is in your population. And you've also got to ask yourself the question, are we doing a test to exclude the illness, or are we doing the test to diagnose the illness? And that's actually a really important question that you need to ask when you're using these tests. When the prevalence is very high, the rapid antigen test has a very, very good positive predictive value. However, as the prevalence gets higher, it becomes less and less able to exclude disease. And, you know, this is all really hard to follow. But I think it's an important thing to try and get your head around when you're using these diagnostic tests. It is a very good infection control tool. And if you don't think about it as anything else, you shouldn't think about it as an infection control tool. We can identify very infectious patients quickly with a rapid antigen test. And the other advantage is it doesn't identify historical cases, which is an issue with lots of PCR testing. So this is a receiver operator curve. I mean, you don't really need to know what this is, but essentially this shows the relationship between the prevalence down here and the positive and negative predictive value. The positive predictive value is that blue line, and the dotted red line is the negative predictive value. And I think I plugged in a few figures like sensitivity of 72% and a specificity of 99.5%. You don't need to know that. All you need to know is, so let's say 10% prevalence and you go up there, the negative predictive value is still greater than 95%, you know? So it excludes, a negative result excludes COVID in greater than 95%. That's all you need to know. But you can see that it's positive predictive value is not very good. If it's positive, you need to do another test. So this is the concept, and it changes. This value changes as the prevalence changes, as you can see. So we'll just get on to more about this. So you have to be a bit cautious with when you're not doing testing with a pathology company like Western's or PathWest or one of the other private providers. We spend a lot of time confirming that what we're told and how a test performs is how it performs. So, you know, there's lots and lots of different tests that are around. Some of them are manufactured in very high quality labs that manufacture things and have good QC processes. Others aren't. You need to be cautious about what products you buy unless you're really sure that they've been assessed and shown to perform as it is in the product information. These tests are much more accurate during the early phase of the illness, so when they're symptomatic and unwell, and that correlates to the highest level of viral antigen. They're not very accurate for asymptomatic patients, so you know they will miss weekly positive patients that may not have symptoms. It does detect viral antigen, which means that there's the presence of viable virus particles, which is the big advantage of rapid antigen. If it's positive, there's lots of virus there. The other thing when you're running these tests is that you really need, and this stuff is done by pathology services automatically, but you need to know that your kits have been QC checked. So you need to run a QC of some form, and you need to get some advice on how to do that. You need to make sure that you keep it in a temperature controlled environment as per the manufacturer's instructions. You need to get adequate training on how to use it, particularly around the lines. So very, very faint lines are still positive generally. And you need to make sure that you've got some good record keeping for both results and the training. You know, that's my desk at the moment with the rapid antigen test while I was doing the, that's at Abbott. So this is really the last page, and then I'll stop talking, which I think is 15 minutes, Benny. Most rats will detect patients who are highly transmissible. That's the most important thing. It will miss people with moderate strength PCRs. This is not your gold standard diagnostic test. This is the gold standard, easy to do test that can be used as an infection control tool. And that's how it really needs to be viewed. You know, you can do it in your office, you can do it with the patient at home. There's lots of different ways to do this, but it's not a single silver bullet. It won't replace a PCR, but it will complement it. And when you use it in combination, and I'm sure Karina will go over all of this in great detail, but when used in combination with appropriate PPE, environmental engineering, administrative controls, you can use it to help dramatically reduce the risk of occupational infection and nosocomial infections. You can't, whilst you're seeing patients as you've got rising case numbers, you can't reduce that to zero, nothing can. but this will complement all of your strategies in your practice. And I think that's it.
Thank you, Jonathan. I might just go to Karina and Jane to see whether there's any comments about rats first. I haven't seen many questions on the Q&A, but people are most welcome to drop those in. But Karina, any comments on the rats?
I actually had a question for Jono. It was with the rat tests, Jonathan, I understand that some of them haven't necessarily been verified with the TGA that they're Omicron sensitive or likely to pick up Omicron. That's what I've heard. What's the truth of it?
Well, I mean, I must admit that, so when I've been looking at a lot of these kits recently in my lab, and they don't have any problem, the ones that we've looked at detecting Omicron. I mean, most of the manufacturers do need to do some sort of work whenever a new variant comes out. And most of the major manufacturers, so we're talking like Abbott, Panbio, BD, Huajin, Roche, Siemens, all of those major people, whenever a new variant comes out, they immediately send a notification to all of the people that buy their products to say that it's been confirmed to work. But really, the Omicron variant, there's no reason why the antigen test shouldn't work. And definitely the experience when we do internal verifications are that every test kit that we've looked at so far can detect the Omicron variant. The sensitivity to which they detect it varies between each kit, but most of them should be able to detect the Omicron variant.
Thanks, Jono. Jane first, before I answer a couple of questions on the panel.
No, I don't think I have any questions at this point. Thanks, Benny.
No problem. Jonathan, Costco have rat kits. Are they okay?
I'd need to see who actually manufactures them. Most of the time, all of these ones that are coming from supermarkets are branded kits from somewhere. So you might find that it might be an Abbott Panbio kit that's been rebadged to Costco kit. And, you know, at the end of the day, it's basically an Abbott product. Most of the stuff that's coming out of the Chinese manufacturing laboratory, which is where most of this stuff comes from when it's not coming out of Europe, is actually really good. The only concerns are as the orders go up and as demand goes up, which it is, sometimes those manufacturers can't keep their quality control to the same level as others. But so far, most of the kits that have been coming through the market, and they learned a lesson with previous products, are actually maintaining a pretty good standard. So the instructions for use, performance characteristics are generally matching what happens in practice.
Thanks, Jonathan. I'm going to save the next couple of questions. One's about preparation in the GP room and the use of rats a little bit later. So I'm going to now pass this to Dr. Karina Powers for your presentation on the other controls.
Okay, welcome everyone. Thanks for coming tonight. If you're hyperventilating a little bit with this upcoming Omicron wave and perhaps a Delta wave on top of it, remember we may get hit by both these viruses from the eastern states. It's not surprising because there's been a bit of what you might call paralysis by analysis. So government agencies frequently wait until sufficient evidence of harm is established beyond a reasonable doubt before they act to prevent harm. And then we end up in a very reactive situation, which is really what's happening at the moment with everyone trying to prepare all of a sudden. So really, ideally in pandemics, and hopefully we've learned this lesson for the future, we act in a precautionary way. Threats of serious, irreversible, cumulative or widespread harm are of more concern than trivial threats. So failing to act is a form of action in itself with some pretty catastrophic consequences sometimes. So this is something for all of us to think about, whether we're in government or management of a hospital, say, or just even within our own private practice, is what can we do now to prevent something that could be set off chains of transmission and cause catastrophe. And here's a good argument for how important it is to look at prevention of the spread of disease, and it is a bit of a challenge. This table's probably from even before Delta from memory. So now we're dealing with Omicron. So when you look at these green columns, you can start to transplant that with a bit of more orange and red, because as I hear from Eastern States doctors in the know, people are even picking Omicron up at picnics outside. So it's important to remember to wear your mask outside, and it will have a significant decrease in risk of contracting SARS-CoV-2. You can see that the other reason why we should be doing everything we can is a lot of people still haven't had their third dose of vaccine, and that third dose of vaccine makes a significant difference to the risk of hospitalisation. Now, occupational physicians work with something called the hierarchy of hazard control. You can see on the right, first of all, we want to eliminate the risk. Then you can do various things like substituting it for something less hazardous, isolating, reducing risk through engineering controls, using administrative controls to stop exposures, and then using personal protective equipment. And traditionally down the bottom of this table, personal protective equipment is the least effective or reliable, lowest level of protection. But a pandemic airborne virus is quite a different situation. And whilst some managers tried to use this table to argue that they didn't need to provide respirators and just surgical masks would be fine, it's not the case. It's an airborne disease. We need every single layer of control that we can practically provide to prevent people getting unwell. So yes, we do need our respirators. So you can consider your practice as its own little country, and you've got to put in place border control. That is, don't let the disease in if you can practically avoid it. So the move to telehealth right now is important. I've moved my own clinic across to telehealth in the main this week. And you've got to consider a risk balance in a pandemic way. If you know the risk that your patient will get infected traveling into you or spread disease to others on the way in and on the way out, and in your own practice, and whether you could pass disease on to them inadvertently. So any staff member or who can work from home, any patient who could be seen from home, it's just less risk for you. Who are the suppliers coming into your practice? Do they have hazard control measures? Do they have a COVID safe plan? Do their workers seem to be in a higher grade level of mask? Best of all is trying to keep everybody outside, and contactless invoicing if you can do it. Education of visitors with signage is important. They don't then have to talk to you or shout at you. They can read something and know what to do. Making sure staff are fully vaccinated. That includes really third dose now, encouraging people to get that. And as Jonathan was just saying, rapid antigen testing is an important tool in that hierarchy of control to prevent disease coming into your practice. And it takes a program of rapid antigen testing to do that. And Jonathan had a slide on some of the setup to consider with that. So it is a significant thing to do, but it is very important. It's certainly protected practices in the East from staff coming into the practice and spreading disease. They've been picked up with a home program. The practice provided them with some RAT. So again, you substitute the hazard as much as possible. I'm just reiterating things because they are so important. Telehealth, work from home. Also consider what's the additional risk for you if people who are unvaccinated are coming to see you. There is an increased risk of transmission of disease between people if somebody's not vaccinated. And sure, some of these people can't be vaccinated for perhaps some medical reason, but they're not there are not so many of those, and the risk is probably low, but it's really, I guess you have some control over who comes in and out of your practice, and people who aren't vaccinated can be some increased risk for yourself and staff and patients in that area. And consider how you're going to protect your patients who haven't been vaccinated, who you are choosing to see and protect. So all levels of control are important. So have a testing plan for your staff. If you pick it up, they can then isolate at home and not come in. And think about what sort of financial arrangements these staff might have access to that you can talk them through. That will help encourage them to do the right thing. Use the RAT test, stay at home. If they're not well, don't come in. So look at the engineering for safe indoor air for your practice. If you have access to a handheld CO2 monitor, or some people may even have in place now wall-mounted monitors, that's really helpful. You could walk through your practice. You can see how opening windows and cross-ventilating works, opening an opposite window or door, whether child-safe fans put in there help your ventilation and drop your CO2 levels. Some people put whirligigs in the roof to increase airflow. Yes, anything that can bring in clean outside air is best. But also we do have to think about when you need to shut the windows in bushfire smoke or increased pollution or incredible extremes of temperature, and plan for that as well. This is just an example of a handheld monitor, and that CO2 reading there at 928 is not really flash. There's different advice around the place. I'm with Aussage, and we've issued a safe indoor air advice that was originally used for New South Wales schools, but there's also Safe Work Australia has safe indoor air advice. But generally the rule of thumb is if it's around about 600 parts per million, that's good. I mean, outside air is around 400, but at 600 is really quite good. If it's 800 parts per million or thereabouts, it's a low relative risk. If it's 800 to 1,500 parts per million, there's a moderate relative risk. You need to make improvements really and to get more fresh air in. If it's above 1,500 parts per million, that's a higher relative risk of infection, and really you should think about evacuating that space and making some changes. If you've got a mechanically ventilated building, you've got to talk to your mechanical engineer to look at how to adjust that in the right way to increase the proportion of outdoor air coming in if you can. And opening windows or doors may not be appropriate in mechanical ventilation systems unless it's checked. Make sure that if you're operating a fan, you're not just constantly leaving it on when it wasn't designed for that to happen. You may cause a fire. And demand control ventilation systems may actually stop fresh air coming in and increase your risk. So these may need to be disabled, but again, you may need someone who's quite smart in this area and not something you should do yourself necessarily. HEPA filters, they work, okay, but it's like everything in the hierarchy of controls. They're not going to work perfectly. You can't just trust the HEPA filter to do everything. They remove large particles. They also remove very small particles. And the SARS-CoV-2 virus is 0.12 micrometers or thereabouts. And it is filtered out, and it's even more likely to be filtered out because it's inside water and mucus, and is therefore an effectively larger particle, and that's filtered with a very high efficiency. So as I said, HEPA filter isn't the answer to everything. If you've got someone directly opposite you yelling in your face and they're unwell with the disease, you hope that you've got all your other controls in place, such as your respirator on your face to help protect you. But they do definitely help with dead spaces in poorly ventilated areas such as corridors, tea rooms. Your room is an extra backup. It's important. And here's just some examples. There's an Australian-made one from Innovair, and other ones. This Samsung one in the middle is the ones that's used in Victorian schools, or ordered for them at least. And then there's a cheaper version here called the My Air Purifier. So there's many more different types. And it's not necessarily the most expensive, delivers the cleanest, best scrubbed air. Some of the more moderate priced HEPA filters work really quite well. So there's some advice on this that's accessible to have a look before you invest in one. Also think about the decibels and how loud it might be. You may want a few smaller ones placed around the area rather than one very loud, noisy one. There's other things to think about with how you set things up, who comes in, little bubbles, or of how people interact throughout the practice. Obviously, basic things, even though we know this is now this is airborne, is one of the main ways it's transmitted. You still got to think about hygiene. Think about acoustics in the practice, like if there's how you can make it so people aren't trying to shout at each other over a loud background noise, anything to soften that echoing noise. And you may communicate through screens or iPads that are dedicated to people. Again, good signage can help avoid having people having to talk to others. Really think about your surge workforce. From everything I've heard so far, it might be 10 to 15% of your workforce could be down at any one time. So what are you going to do about that? How are you going to manage it? And think about keeping your staff in their bubbles. So if you happen to have a doctor married to a doctor, can they both work the same time? Sometimes it's possible, often it's not. But if it is possible, it's worth putting in place. Then you don't have a cross-infection of other staff. If there's a point here about high touch substitution, I mean, that might be an investment for future pandemics. It's not something you can necessarily scramble together right now, but things like no touch toilets or those sort of changes are important. Yes, and listen to your workers. If they said, look, there was a near miss with something, they may have some good advice on how to improve the risk for the practice. So respirators are incredibly important. These form a very close seal around your nose and mouth and protect you from being exposed. So you're actually breathing through the fabric of that mask, and it's not just coming in from around the sides. So P2 respirators are Australian, New Zealand standard, N95 are United States, FFP2 is European, and KF94's got to the Korean standard. These are all good options, and there's multiple places you can order these in. I mean, at the moment I'm wearing a Pro Shield that I picked up at Chemist Warehouse for $5. And it's just sealed really well around my face. I was just lucky. The KN95s are not so popular anymore because there's been a significant amount of counterfeit reported. So yes, all those other ones are good to get now, and in a bulk stock, you're going to probably need them for a few months, and for any new variants or pandemics that are coming through. So. And you can see here that if you're both in fit tested N95, it really drops your risk of having an infectious dose. So that's the bottom line and the far right line intersecting. And the good news is you can, so if you fit tested your practice, that's really making a significant help to cutting risk of disease. But non-fit tested N95 also are helpful, much better than a plain surgical mask, that you'll see in one of my later slides. And you can reuse them. So even the inventor of the N95, he put them in, he says you can store them in paper bags. So you might cycle through them every 5 to 7 days. The reason is because there's some evidence of live virus after, say, 72 hours on some surfaces or types of materials. So 5 days gives a nice safety margin. That's something that was recommended in the CDC as well. So yes, you can dry your mask out every day and wear it until the elastic isn't causing a good seal on your face. Then it's time to change it. And that may be as little as 5 times of use or 20 times of use. It depends on the brand. So wearing a respirator reduces the risk of infections when it's planted on your face by 2.5 times compared to a surgical mask. And again, that next paragraph is just about how well, the distance, you might think you're safe at 3 meters, but you're not necessarily, and wearing respirators really drops that risk right down. For those who cannot access a respirator, there's evidence that the fit of a surgical mask can be dramatically improved. So there's things called bracing, double masking, knot and tucking, and toggles. If you've run out of your respirators, you really should look ahead on how to adjust your surgical mask supply and plant that on your face and seal it well. This is all good advice. We actually do have an Aussage document hopefully coming out on Monday about community masking, which has links in it talking about these things if you don't already know how to do any of this. This table just shows the improvement to protecting your inward air from some of these changes to a plain old surgical mask, and it is significant. You can also order some stock in for children to help cut the risk in the practice, and they may be quite happy to take that home and take it to school. The child's over 2 years old, they can wear respirators, you know, as long as there's no disability or developmental issues that makes it harder for them. But everybody that we can put in a respirator, it helps cut the risk of disease. Some patients of yours, or indeed other staff, may find it really quite difficult to wear a respirator and, you know, may tolerate a loose surgical mask, which does help to some extent. Some people with high risk, you may want to tell them, please get formally fitted, that if they can afford it, because that will help also to reduce the risk of infection. The respite may do it. I think AMA was setting something up too, probably. So there's that would be for staff, I would assume. But yeah, for patients, you can refer them to respite. These are just some examples. The KF94 on this right-hand side is more the children's sizes, I think. And then you've got, but adults can use KF94 too. There's a 3M Aura in the middle there. Bill Biden was seen in one recently. And there's a example of a P2, that blue, light blue mask. Down the bottom is an example of a half-face elastomeric respirator. That's the Sunstrom one. The Eastern States doctors seem to like. They have a microphone with that one. And that's a reusable one, once you've got a HEPA appropriate, virus appropriate filter in. So do think if you're in a pandemic now, you will suddenly find that key business personnel are taken out, unfortunately. And so you need to be able to replicate your personnel, information knowledge, think about your surge staffing, look at all your, like what the state and Commonwealth are recommending and that you have to follow by law. What I'm asking you to do tonight is perhaps well above what state health may ask you to do, but it will definitely help cut your risk to put in place some of the things I've mentioned tonight if you can practically and financially afford to do so. Make sure you've got adequate stocks of PPE and N95, etc. I forgot to say, of course, you're in a medical practice, so sometimes it's not appropriate to keep reusing something if it's getting contaminated between patients because of the risk of disease. So some reuse may not be appropriate, but some things aren't so dangerous from the infection point of view, and you could reuse it. Be prepared to do your own contact tracing. As we've seen, that had collapsed in the eastern states. Thanks, Benny.
Thank you, Karina. Very comprehensive advice across a lot of different topics. Obviously, we didn't get to dive down into each specific area, but just listening to your advice about the N95 reuse, especially given the supply issue at the moment, is very enlightening. So I'm just going to give you a bit of a breather before I throw some questions back at you, Karina. I might just start with Jane first at MDA, because one of the most common questions that's actually come to us, and I'm sure to you as well, it's when you are at a clinic, whether you could actually refuse to see unvaccinated patients. What is your advice, and how would you actually manage this situation?
That is a short question, which is needs a fairly long answer because the situation is quite complex. So it's a matter of your particular circumstances, but you have to balance up a number of competing things. One is to to bear in mind that, of course, vaccinated patients can also carry disease and infect your staff. So it's not a matter of if you kept all unvaccinated patients out, you'd be safe. You need more things at your border than just that. You do have an obligation to provide a safe working place for your staff. But at the same time, people who are unvaccinated for whatever reason do still need to access medical care. And you're not obliged in private practice to see any patient, but your reasons for not seeing patients cannot be discriminatory. So bearing all of that in mind, I think you need to look at, and we've gone through a lot of this stuff from Karina. So think about your triage of patients before they even arrive, the information that you receive from them. Think about the type of practice that you've got. Can you switch completely to telehealth? For a psychiatric patient, for a psychiatric practice, that might be suitable, but there are other practices where patients are going to need to access care in some way. So you might have the facilities and staff and layout to be able to take those additional precautions, or you might decide that you're going to see those patients at the end of the day when you have the rooms better set up to monitor that risk. Or you might decide that you'll do a telehealth, and if they need to be seen face to face, you'll refer them somewhere else. So it does very much depend on your particular circumstances. And I think it's important not to be, what's the word, too confrontational about it, although sometimes that confrontation does come from the patients, unfortunately. So it needs to be handled sensitively. And I do feel for reception staff at practices, because they have to deal with a lot of stuff these days.
Jane, as a follow-up, do you recommend practices to, in fact, document this as in some kind of policy, to turn them to signage? What some practical advice could you give them to protect yourself?
I think now is a good time to have a practice policy and look at how you're going to manage this risk. And I think information to patients ahead of time is very important, so patients know what to expect and they're not caught out when they get to the practice.
Are there any standard templates that are floating around, or is there, or do people really have to come from the ground up in that regard, Jane?
I think the RACGP has got something, and we've got some information that we can send out about links to policies for practices to have.
Thank you for that. So I am going to go back onto the Q&A now. So I thought that you were very comprehensive, Karina, but there's a question about eyewear. Any comments or recommendations in that regard?
Yes, I figured someone would notice I hadn't talked about gloves and eyewear and all of that. I really wanted to focus on the safe indoor air and respirators, but you're right. If you can put on some goggles or safety glasses that fit quite close to your face, it could well stop that small risk of transmission through ACE inhibitors in the eye. I'd be interested to see what Jono has to say on this matter. Yes, there could be some small risk of transmission that way. So it is a fair thing to think about.
Jonathan? Unmute.
Can't stop doing that. Sorry.
First time in 2022 saying that.
It's generally recognised that any mucous membrane has ACE receptors and potentially is a source of an infection. However, I mean, the eye, whilst it's very important and close-fitting eyewear is recommended, and that comes in the form of safety glasses, goggles, face shields for those that wear prescription glasses. I think that there is a general feeling that the higher risk mucous membrane for infection is your respiratory tract, because there's probably more opportunity and more air movement and potential risk from getting infected that way. But it's definitely not to be ignored, and particularly from a droplet precaution perspective for those that might do aerosol generating procedures, like protecting the eyes from splatter saliva is very important because it is a well-recognised reservoir of infection.
Jane, just on a medical legal perspective, do you actually have to document, what you're wearing in terms of PPE, when you're actually starting a clinic, a session? Does that actually, help, a little bit down the track, God forbid, medical legally?
We haven't had particular problems with that, but I guess that comes back to your practice policy and what you've decided is appropriate PPE or protective wear for the type of clinic that you're running and the patient cohort that you're seeing. So it's obviously going to be a bit different if you are seeing patients with symptoms or patients who are presenting for completely unrelated things.
Thanks for that. Karina, this might come back to you. Many in the GP or private practice consultation room are air purifiers of any use, and can you elaborate a little bit more about HEPA filters, especially when you don't have windows, please?
Yes, I would say if you've got a room that's a dead space, I mean, ideally, HEPA filters will make a difference, that's for sure. But I'd be really tempted not to use that room, just for the reasons I was saying, that HEPA filters are great. They will lower your risk, but it's good to have some ventilation and shift of air, clean air coming in. That helps lower the risk further. So yes, I guess if you had a lot of high scrubbing filters in a real dead space room, it helps, and certainly it can, if you also lower the occupancy of that room. But I think if anywhere you can have good ventilation included, extra airflow is important. Better if you have that better choice, use it.
I think the challenge of many clinics is obviously, the difficulty in one, who do you actually get the assessment, where do you get the assessor from? And then what can you really practically do? And I think a lot of people go, okay, well, if I can't change room, what can I really, buy right now to protect themselves? So it's very difficult.
Yeah, it'd be the layers of the controls. If you really have no other room and you really do have to see the patient, HEPA filters are really important, but also, wearing your N95, fitting it well, giving your patient an N95 to put on before they get in the room with you, rat testing them if you can before they come in, really just trying to put all the layers of controls you possibly can in.
Well, just on that, that's a good segue. The first question was, how do you use rats at the moment, Jonathan? Someone runs a GP clinic and private practice, in what context and how?
So, I mean, when there's significant prevalence of cases, in many places in the world and the eastern states, some practices have been using them quite routinely to screen even asymptomatic patients. However, all of this needs to be really a combination of what is the actual risk of the patients presenting to your practice, what's the prevalence, what's the caseload, and the reality is that you've got to ask the question, what are you using it for? So, if you're going to have a whole bunch of patients sitting in your room, and there's some way of you getting those patients to pay for the rapid antigen test is another consideration. And they were going to be there anyway, and there's a high risk that one or two of them could be an asymptomatic carrier. It might be a strategy as well as everything else that you need to do to try and prevent sort of acquisition in your waiting rooms and things like that. So it's just, it's not a straight answer, how do you use this? It's like, can you use it? Can it be implemented into your practice? And if so, how are you going to do it? Where are you going to do it? And where are you going to do it safely? But it is a good infection control tool. And it's obviously being used extensively or planned to be extensively used in the West Australian hospital system, and it's being used extensively in other parts of the country, including Northern Territory. It's basically taken over from PCR testing, which it may not be the best thing to do, but it is being used extensively in hospitals and other practices.
So I guess in the
sorry, Benny, I just want
yes.
to say I have heard of some practices moving to see their patients outside even now. So they'll start seeing them on their verandas. They put up shade cloth and yeah, more work outside if they can.
I think the challenge right now is to supply rats, and when it comes in, you know, people would get a lot more proactive in, you know, how you implement it. But right now, in Perth, as you know, there are some community transmission. Is this the point where you start implementing all these? That's one of the questions here. Like N95, work from home, and HEPA, etc.
Yes.
So the reality is that yes, you probably need to start thinking about it. I think when you really need to make sure that you've implemented some of these strategies is when the health department, the chief health officer, comes out and starts escalating their escalation plans. And you know, we're not far away from it. And if you don't have if you're not already doing some of these things, and if you haven't got a plan to access some of these higher level controls like Karina's gone over, you really need to hurry and get some of them in place.
Thanks, Jonathan. One question here. If surgical masks aren't mandated, what can we suggest before patients come in wearing only cloth masks, or when they wear it very badly? Would you suggest giving surgical masks out to patients?
I'd suggest giving N95 out to patients as long as they're able to tolerate them, or at least offering them. It's just shown that that'll help drop the risk. So ideally, the community now is going to move towards N95s as this disease becomes more prevalent. It's going to be very helpful.
I will say though, pragmatically, not all practices have enough N95 masks to give out, and a surgical mask, as the name suggests, is designed originally to stop droplets, and it's quite effective at stopping very small particles from leaving the mouth of an infected person before they have an opportunity to become aerosols. So it is still a very effective measure to prevent transmission, is to apply a face covering. But yes, an N95 mask will do it better, but we may not have the luxury of having them to hand out to.
Yeah, I suppose you could hand out surgical masks, get them to put it under their cloth mask. You might have someone who's very good at showing how to do knot and tucking or toggling or something like that with the surgical mask to improve it for them. Yes.
Okay, now we've only got a couple of minutes left, so I'll try to squeeze in 2 or 3 more questions. The first one, Jane, in the practice, are you allowed to ask individuals their vaccination certificate?
The answer is yes, you can. It has to be done sensitively, and it has to be a reasonable request. So depending on what's happening in the community, COVID spread, it may be helpful and necessary to ask that question, but it should be asked sensitively, and who asks it is an important question. A lot of people may feel it's a bit intrusive if the receptionist asks it first up, and it may be something that should be recorded by the doctor in the same way that we would record other health information about vaccination, smoking and so on. Yes, because so it's going to be important information in particular circumstances.
Yes, because it does drop the risk if they have been vaccinated, and you may want to see the unvaccinated at a different time to others. Yes. You may want to have time to flush that room out with some good air and manage it in practical ways, that risk.
Exactly, and of course there are significant additional risks for people who cannot be vaccinated coming to the surgery, so they need to be protected.
Thanks for that. I think this one is for Jonathan. What is the risk of reinfection after recovering? Can we relax after you've recovered from COVID?
So whilst it would be nice to think that Omicron could be the end of it all, it probably isn't, and we're probably another vaccine escape variant away from the next sort of surge in activity in sort of 3 to 6 months' time. The Omicron variant caused infection in 2/3 of people that reported infections had previously acquired COVID before in the UK. So really nothing's certain, and there's a very good possibility in the future that there could be another one of these variants that may infect us, even if we've been double, triple, quadruple, maybe 5 vaccines later plus been infected. We just don't know yet. I hope not, but anything's possible at this stage.
And the other thing to think about is your organs take a hit every time. Even if you're vaccinated, if you're getting breakthrough, you've got to think that what's happening in your body, it's not a great thing to keep catching.
But I mean, it is largely in vaccinated people. It has been a very, very mild disease. Like a lot of people getting Omicron who have been boosted didn't even know they were infected until the day that they had a little bit of a headache or something like that. Seems to be a number one symptom is a headache out of the blue, and then it goes away, but people are infected with it. But it's fairly self-limiting in lots of vaccinated people.
Well, I might just wrap the direct Q&A, and there's actually a couple of other questions here that I just want to address collectively. One is about the risk matrix. And for those who don't know, the risk matrix is a tool that actually helps you to risk stratify patients based on what controls that they had or what you've got, so that you can say you've got low risk, medium risk, or high risk, and how therefore it impacts your staff in furloughing, etc. We at AMA, with other peak bodies, have been advocating for the WA government to push that out, finalise as soon as possible. In fact, today I was pushing that, at the minister's level and also as well as the department level. We need that risk matrix, and we'll continue to push for that. The other common question here tonight is about whether you'll get a copy of a slide. We will be emailing everybody after this tonight. I will seek permission from the fabulous speakers tonight and communicate that with everyone here. I just want to take this opportunity to thank all the speakers, to Jonathan, Jane, and Karina for sharing us your insight. I know that we haven't got a lot of time, but this is a start. I want to thank everyone who's attending. In WA, as you know, we are in a different timeline compared to eastern states, and there is a lot of information that's being developed, a lot of policies that's being developed or announced on a daily basis. So what we have done is to set up WhatsApp groups and Facebook groups to allow everyone to share their knowledge and experience. We will send that out after the meeting. Over the next couple of weeks, we will ramp up in terms of both the forum, sharing information from doctors to practice managers as well as experts. So in 2 weeks' time, we will have one webinar just on fit testing. And I will also be communicating with everyone about the supply of rats, about the PPEs, including the N95 masks, and also about the much needed fit testing service that at AMAWA we will introduce. So watch this space. I will drop everyone an email tomorrow. So I hope everyone will have a good night, and I will see you again next time. Thank you.